Thank you, Anna. I'm delighted to be able to chair this portion of the conference where we have 4 distinguished speakers in the area of digital delivery of healthcare. And first up, we have, I'd like to warmly welcome Chris McCann. And Chris is the Director of Communications, Insight and Campaigns at Healthwatch England. And prior to this, Chris worked in central government at the Cabinet Office, where he worked as Head of Strategy and Policy for gov.uk and Head of Media and Strategy Liaison at the Government Digital Service. And previous to that, he worked at the Department for Business as Deputy Head of Strategic Communications at the Department of International Trade as Head of Media Relations. So there's more even to tell, but we don't have time. And he has worked he has over 20 years of communications and journalism experience. And today, Chris is going to speak with us on locked out, digitally excluded people's experience of remote GP appointments during the COVID-19 pandemic. So with no further ado, I'll hand over to Chris.
Thanks very much, Adele. As you might guess from my accent, I might represent Healthwatch England, but it's not where I originate from. So I think it would be useful just to give a quick run through in terms of what Healthwatch England is, because I don't think there's a direct equivalent in Ireland. So Healthwatch is England's social and health care champion. Our job is to seek to understand people's experiences of GPs, hospitals, dentists, whatever, all the elements of the care system, care homes, other support services, but we're not a regulator. That duty sits with the Care Quality Commission. But as an independent statutory body, we have the power to make the NHS leaders and other decision makers listen to public feedback and improve standards of care. So for instance, last year I think we helped over 1 million people to have their say on various issues and get information and advice that they needed. So whatever area of England you would happen to visit, there'll be a local Healthwatch. There are over 150 across the country, one in every top tier local authority area. Healthwatch England, we're responsible for coordinating all that work and sort of leading on strategic direction. But we're here to listen to the issues that really matter to local communities and to hear about their experiences of using health and social care services. But we're entirely independent and impartial, even though we have a dotted line into the Department of Health. And any information or any contact that people make with us is completely and utterly confidential. So what I'm going to talk about today is our findings around digital exclusion around primary care as a result of the pandemic. So just as a bit of background on this, digital transformation has been a big long-term strategic goal for the NHS, and the new long-term plan that was created in 2019, it committed that every patient would have the right to digital appointments by 2023-24. But the pandemic forced a rapid acceleration of this process. So there was research from the Nuffield Foundation that showed that in January of 2020, less than 10% of GP appointments were taking place digitally or remotely in England. And by April, that had accelerated to almost half, 48%. So obviously, when you've got a transition as quickly as that, there will be gaps that are almost unavoidable. In terms of trying to cover the rapid change that was needed during the pandemic, but maintain the levels of care that people expect to receive. So we hear a lot about access to GPs. Access to GPs and access to dentists are actually the two things we hear most about, but particularly GPs. But that ramped up even more through the pandemic. People were struggling to access the care that they needed. So, having looked at the broad range of feedback we were getting, we decided to do some qualitative work to have a look at the experience that specific groups were having in terms of difficulties of engaging with GP practices during the pandemic. So we tried to make sure we worked with 5 local Healthwatch to do a representative areas from different parts of the country. So you've got Darlington in the northeast, Dudley in the Midlands, Haringey in London, Swindon in the west, Wigan and Lee in the northwest. And we interviewed 86 patients, 26 members of staff. We interviewed 34 older people, and we interviewed 31 people who had some physical, mobility, sensory impairment, learning disability or long-term condition. And we interviewed 21 people for whom English was a second language. So in terms of older people, we're categorising that as people over 65. And disabled people, we were particularly interested in people with sensory impairments, learning disabilities, or dexterity or mobility issues. In terms of people with language barriers, we wanted people who had limited proficiency in English. Local Healthwatch identified non-English languages widely spoken in their area and used an interpreter for their engagement work. We also carried out work with professionals working in primary care to get their perspectives of people's experiences and to have that context, that clinical perspective. To ensure everyone interviewed had the same level of care and digital services offered, we asked Local Healthwatch to recruit participants from a single GP practice or a PCN. An interview guide was created by the project group made up of Local Healthwatch and Healthwatch England to guarantee that the data was collected as comparable as possible. We wanted to understand the experiences of people who live in relative social and economic deprivation. Due to lockdown restrictions, Local Healthwatch found it actually quite difficult to recruit participants from lower income households or those who are completely digitally excluded, which obviously speaks to the issues that caused us to do this piece of work. Local measures also meant that we had to carry out the interviews remotely. These were mostly by phone, some were by Zoom calls in a small number. That was usually done to facilitate interpreters. Online and telephone surveys were used to gather more information from some professionals and patients, respectively, but we recognised that remote methods were not ideal for reaching a population at greater risk of digital exclusion, but circumstances meant we had to work within the parameters that were available to us. So, what we discovered is that there are sort of basic categories of why people struggle to use remote methods to access GP appointments. One is a limited interest in digital technology. Second one is a lack of digital skills. Thirdly, age and disability. Then lack of trust, language barriers, and finally, affordability. If people fall into several of these vulnerable characters, if they have intersectional barriers, then obviously the likelihood that they're digitally excluded increases. Participants often mentioned that they weren't interested in accessing healthcare remotely, even if they could. However, our experience taught us not to take those statements at face value, because often people who had difficulties using the systems wanted to use that, were using that as an excuse as to why they were struggling to access care. You know, they didn't want to say the fact that they were struggling to do it. So, first up are the people who prefer not to use, who have limited interest in using technology, and so we had participants who expressed it as a matter of personal choice, and primarily that was a lack of interest in developing any digital skills or the digital skills required, which we found across all the research groups. Now, limited interest in technology can come from a number of factors. There is a lack of confidence in using online services. Others know how to use technology. You know, they've used it through their work, but they don't really want to do it to access their healthcare for a range of reasons. And other people just aren't keen on developing new skills. Older people who just said, look, you know, I'm past wanting to do that. I just want to be able to access healthcare in the way that I've always accessed it. So they find it time-consuming, and it's far easier to talk to someone face-to-face. So many participants remain digitally excluded because they are unfamiliar with technology. Older participants were more likely to have never used the internet or a mobile phone. And sometimes they were even concerned about damaging what they saw as expensive devices, you know, if they were trying to use other people's. People can struggle to develop the digital skills for a number of reasons. Can be because they lack the facility and resources. Specific disabilities such as sight impairment can be an added disadvantage. If people can't read the resources to improve their skills and don't know how to access training materials in accessible formats, then obviously it's near impossible for them to be able to use the systems that are being put in place by providers. People without adequate digital skills also can feel flustered by technology, even if they have access to the technology and the devices required, which obviously you don't want people feeling flustered and uncomfortable when they're doing an interaction with their healthcare provider. Limited digital skills also have confused participants using online platforms and discouraged them from using these services. For example, some people aren't aware that when they're using their GP website online, that it looks different on their mobile phone than it looks like on a desktop, and people are very, very easily sort of put off their stride by those kinds of things. Some participants depended on family to help them use online and telephone services such as booking GP appointments. These people were particularly vulnerable during the COVID-19 lockdown because obviously the restrictions meant that they were less likely to be able to engage family members to do these things for them. And while turning to family can be a great support, some people find it uncomfortable to discuss sensitive issues with their doctors, such as those, if you have an issue related to your mental health or sexual health, people didn't want the family member involved in those conversations. So lacking digital skills can put people off getting any help if their only choice is a remote consultation. I've done a Boris Johnson here. Lack of digital skills. Yeah, I've just covered that. Here we go. Sorry, apologies for that. For the want of a stable. So, on age and disability, our interviews showed that old age and disability can impact people's confidence and prevent them from accessing technology and digital healthcare platforms. One example we had was of an older person who had tried using digital technology with assistance, and it had worked for them the first time, but then when they tried to use it again on their own, they couldn't do it again, and that really affected their confidence. They didn't want to go back to ask somebody to help them to do something that they had previously already been shown how to do. And even when keen to learn, some people don't get adequate support. If you're depending on a family member, that can be tricky. People can be impatient in helping older people to use digital technology, and it might not be an option for everyone as well. Not everybody has somebody who can come along and show them how to use a particular system. On the other hand, some people are comfortable on depending on family to help them access digital healthcare services, so they don't feel the need to learn the new digital skills. However, as highlighted above, those people then were faced with a barrier if their family members weren't able to visit them during lockdown. Some sensory impairments, such as hearing and sight loss, can prevent people from using online services, making them reluctant to try digital healthcare services, so as a result, they prefer face-to-face interactions. For example, participants using hearing aids said they struggled to communicate over the phone or via video call. People with sight impairments are unable to read the instructions unless they're in Braille. This makes them reluctant to try digital systems. And people with physical disabilities can also be a barrier to online healthcare. For example, people with disabilities affecting their arms can't use a computer or a touchscreen phone easily. Holding a phone for a long time to get through to a GP practice can be equally uncomfortable. Fourth barrier was a lack of trust. So several participants feared their privacy and confidentiality would be compromised online, and they preferred to stay digitally excluded for this reason. People were concerned about online scams. Many people were uncomfortable with sharing private medical information via online platforms. They didn't know who could access their details. For example, one respondent had a deep concern about whether GP receptionists might see photographs of their conditions that they were submitting for online consultation with their doctor. Some people just find the technology invasive and are uneasy about using it, or about using anything that could identify them, such as video calls. And others remain wary of what they see as a rush to adopt new ways of working remotely. In general, what people want is reassurance from their healthcare services about the quality of care, and it will not be compromised as a result of being delivered via a digital platform. The fifth reason we looked at was language barriers. So people with limited English proficiency, especially the elderly, struggle to express their needs over the phone. They tend to rely on body language and the facial expressions to communicate with their doctors during an in-person appointment, which makes remote appointments very difficult for them. People with language barriers often depend on family to translate their needs during remote consultations, which, as I said earlier, can be off-putting depending on the nature of the issue that people are seeking to discuss with their GP. And another barrier is that most of the online information is in English. So if you have a language barrier, including those who use British Sign Language, they find it hard to understand the instructions on how to use the types of platforms that are being utilised for remote consultation. For example, if you're trying to book or confirm an appointment on an English-based website, that is a problem, and it prevents somebody from maybe downloading or utilising a GP application such as Ask My GP. Then the final barrier we looked at was affordability. Most of our participants could afford technology, such as the internet and a broadband connection, which allow them to engage with online healthcare systems. But for a minority, affording computers, smartphones, and an internet connection is difficult. When people can afford the technology and an internet connection, that doesn't automatically guarantee digital inclusion, but it is an essential first step. We found that when people can afford the technology and have digital literacy, they tend to use online services and are more willing to engage with digital healthcare. Many participants were confident using online applications, such as ordering repeat prescriptions or having remote consultations with their GPs or sending pictures to their doctor. We have noted that people who can afford and access technology and have the right skills appreciate the advantage of digital healthcare and are more interested in learning the skills they need to develop their digital capacity. We heard from a disabled person with a monitor and mobility issues who had upgraded their broadband package for a faster connection, specifically so that they could communicate with their GP via a webcam, which made their digital interactions much easier. When people are unable to afford technology, they are excluded just at that initial point. Our data suggests that when people cannot use digital healthcare facilities, even when they want to, even if they want to, are willing to learn the relevant skills, in some cases it can impact their willingness to engage with services altogether, which is especially relevant for those who are on a low income and disabled people who have additional costs. This all comes off the back that people found it more difficult generally to access face-to-face appointments during the pandemic. People were usually able to access a face-to-face appointment eventually, but they felt if they really needed one, or were unable to use remote systems, but it often required a lot of persistence and repeated escalation by patients or by their family members or by friends. Usually people are asked to have a phone appointment before a face-to-face appointment can be booked at a clinician's discretion, and for those for whom a phone appointment isn't suitable, say somebody who has issues in terms of a hearing impairment, obviously that's quite a substantial barrier to overcome before they get that face-to-face appointment. And people who were regular visitors to their GP were really frustrated at the lack of proactive communication about how visiting arrangements would change. So we have examples of that where, let's say the systems that were used, you would go in a different door or one-way systems. The lack of clarity and how that was communicated was really, really off-putting, again, particularly for older patients who routinely visit their GPs. But it's not true to say that remote care is a barrier for everybody. Actually, there's sections of the population for whom it works really well. So people who have mobility issues, they were likely to say that actually the switch to digital appointments had been really helpful for them, since they were, were able to avoid trips to the practice, particularly those who have to use public transport. Also, people with caring roles found it easier to talk to their doctors remotely without worrying about having to arrange how they would have cover for caring for a loved one while they were making their visit to the GP. But the most common complaint we heard about was the difficulty of getting an appointment in the first place. Many were reporting phone lines were always being busy, or available appointments were fully booked, even when they rang first thing in the morning. One of the things that actually can make a big difference is if practices have the right telephony systems in place. If you have a telephony system in place that allows people to understand where they're there in a queue, when they're likely to actually get through to the doctor, etc., it just makes it so much easier for the user to have that experience. Whereas we had examples of people maybe hanging on the phone for an hour waiting to talk to the GP. There was issues with total triage, which is the policy that the government issued, which was that all GPs were told to look at remote appointments first in 2020. People were told they could only book through the Ask My GP app, and then they weren't being supported by reception to make bookings via an alternative method. This led to several of the patients that we spoke to actually just abandoning their attempts to seek care. And obviously, if people aren't seeking care at that early point, then conditions can worsen, and what it does end up with is the backlog, because these patients almost inevitably end up at A&E. So finally, language barriers presented a significant issue for phone appointments. Variation across practices. There was variation across practices as to whether an interpreter was possible on a phone consultation. So there's that lack of uniformity in terms of what different practices were able to provide. In terms of their experience of remote care, the three groups we spoke to reiterated similar frustrations with telephone appointments as the sample from the general population we spoke to for some previous work we had done, particularly not knowing exactly when a doctor will call within a time slot. And then the other issue that people routinely come back to us about is that that need to make a call at a time slot between 8 and 9 o'clock in the morning, when if you're a parent or a carer, you're maybe trying to do the school run or trying to get to work, so that, that it adds in an extra barrier for people. People also experienced a range of challenges accessing care specific to their conditions or demographics to do with their digital skills or literacy. Some older people with hearing impairments said they found it difficult to hear on the phone. I'll tell you what I'll do. I'll skip on towards the conclusions. Overwhelmingly, people expressed a desire for the choice of what kind of appointment works for them. There's been a lot of narrative in the media, certainly in England at the minute, that's saying face-to-face appointment good, digital appointment bad, but that's not the case. For lots of people, digital works well, but people want to know that they can have the appointment they need when they need it. So if they need a face-to-face appointment, they want to know that it's available to them, even if initially they're happy to have an appointment via a remote method. So staff, again, also very supportive of a hybrid model. But I think I just skipped to, we had sort of put down some 5 principles for post-COVID digital healthcare. One is to ensure that remote methods are maintained alongside traditional models of care and supports patients to choose the most appropriate method of care to meet their needs. The second is to invest in a support program to give as many people as possible the digital skills they need to access remote care. Third one is to clarify patients' rights regarding remote care, ensuring people with support or access needs are not disadvantaged when accessing their care remotely. Fourth, enable practices to be proactive about inclusion by recording people's support needs. So if your practice is aware that a telephone appointment isn't suitable for a particular patient, they shouldn't be being offered a telephone appointment. That's an example. And then fourth one is a broader issue. It's commit to digital inclusion by treating internet as a universal right. Not specifically, not in all cases, but for the requirement of accessing essential services. And that was also a recommendation that was put forward in a recent report by the House of Lords, Beyond Digital. The fact is, nobody should be excluded from accessing their healthcare because they can't afford the devices and platforms required to do it. So Apologies for whistling through that. I got caught up a bit there. So happy to take any questions. And also my contact details are on that last slide, should anybody want to get in contact with me. Although if you go onto my Twitter feed, you will just largely find me complaining about the Derry Gaelic football team.
Thank you very much, Chris. That was very valuable findings there in terms of identifying the barriers and the exclusion possibly of very vulnerable groups. And while digital technology is wonderful, it's not all about just affordability. It's about usability as well, and the other psychological barriers of frustration, which I can identify with my own people at home. So I'm just going to open just very quickly, just in terms of time management, if there's any questions from the floor. Go ahead, Ada.
Did you find that you talked very much about the patient response, but you also interviewed staff?
Yep.
Was there a sense among staff of frustrating using remote, or were they all very positive about it?
No, they had.
Sorry, Anna, do you want to just actually come here?
Sorry, I was just wondering, with regards to staff, I know you interviewed them as well. Did you find that there was a positive sense from them about it, or did they also have problems or challenges linked to remote consultations?
Funnily, the response from staff, and we interviewed like a range of staff, including GPs, receptionists, nurse practitioners. We interviewed a practice-based pharmacist. Was that it was the same as we got from the patients. It was about making sure that the right method of interaction was available for the right patient. Now, depending on the practice, some practices were much better at this than others. They were much more advanced at it, but they did share patients' frustrations, because obviously, if you have a patient who has had quite a difficult journey to navigate to actually get to you, well, then that makes for a harder interaction. But in general, staff are in favour of that hybrid model, as long as they can ensure that the patients who need to have a face-to-face appointment, so particularly say somebody who's experiencing a new condition, has the ability to access it in that manner.